at least online this time. And today there are almost 1,000 participants online in our Congress. And I know that many of them are waiting for your talk, and your topic was one of the most desirable. Because it's very interesting, generally a very interesting topic. So I propose to start your presentation and then answer some questions. Please.
Great. Yeah, great. So hello everyone and welcome to my talk. I'm very happy and honored to give a talk about immunotherapy in recurrent miscarriage. First of all, my conflict of interest, we receive funding and do clinical studies with the mentioned companies, and I'm a shareholder of Reprognostic, and as Udo Margot also, we are focusing on uterine NK cell, plasma cell, and regulatory T cells. So although the former speakers already mentioned that there are different kinds of definitions with regard to recurrent miscarriage, I think this is very important to have it in mind, because when we now talk about possible immunotherapies, we have to keep in mind that the studies are based on these two definitions. So some focus on patients with only 2 consecutive losses, and some use the WHO definition. And so this makes it quite difficult to compare the studies. When we look on our own patient, we see the same, like the others already showed, that we have nearly 50% of patients with unknown origin, or where we do not identify any risk factors like thrombophilia, autoimmunological disorders, genetical, anatomical, or endocrine disorders. And I think this is the main problem we are dealing with, and that's why we are all interested in new data on immunotherapies, because we have the patient demand, we have few empirical therapies, and definitely insufficient fundamental research, and we all are lacking a good understanding of the immune mechanism. And that's one of the major problems in all countries. We have a low priority on research funding as compared, for example, to our colleagues from the Department of Oncology. So I think there are several studies which are focusing on the role of immunotherapy in patients with recurrent pregnancy loss, as well as patients with recurrent implantation failure. But the problem is that we have mainly no clear targets. And so we cannot say whether it's a clear effect or whether it's by chance. And that's why I'm going to focus today on some immune cells. Although we know that there are several immune cells, and I think in the talk of Udo, we got a nice overview. I think the major player we are having at least some data are plasma cells, Udo already showed us, but also NK cells. And so first of all, some notes on plasma cells. I do not want to repeat, but as a clinician, I want to stress that we have different kind of diagnosing, different kind of methods to diagnose chronic endometritis. And I think we all grow up with hysteroscopy, and we are doing this a lot with our patients with infertility or recurrent miscarriage. But nevertheless, it has a low sensitivity and specificity to detect a chronic endometritis. And then when we send the material, the tissue, the endometrial tissue, to the pathologist, and they do a HE staining, of course they can see some differences, but also with a low sensitivity and specificity. And that's why now we can say that's a gold standard to diagnose chronic endometritis, to use CD138. And when we look on the studies which are published so far, and I like the Liu paper putting together the data, and we focus today on recurrent miscarriage, we see the main problem that we have so far diagnostic criteria which differ within the studies. And also the timing of the endometrial biopsy differs within the studies. And that's why we have a prevalence from 9 to 56%. And we all agree that 56% seems a little bit too high. But as Udo mentioned, we have a clear therapy. So doxycycline is mentioned as a first-line therapy, and then ciprofloxacin and metronidazole as a second-line therapy. And I think this is now proven, and we will also have it in our guideline, in our German-based guideline for Austria, Germany, and Switzerland, that if we have diagnosed a chronic endometritis and we treat it, that we definitely see significant higher live birth, clinical pregnancy, and implantation rates. As I mentioned before, I'm not going further with the plasma cells, but will focus now on NK cells. Udo already showed us that we have different kind of NK cells with regard to peripheral blood, which are more cytotoxic, and with regard to uterine NK cells, which are more regulatory. And therefore, we think that they have to be regarded separately concerning their function and especially their origin. And the main problem is how to measure them. So we do FACS analysis with peripheral NK cells, and we count the numbers and the percentages, but there are other groups looking at the activity, and I think this is a very interesting marker to look on activity markers like CD16 and others, because then we can have more information about the NK cells. And the same is true for the endometrial NK cells. We also can do immunohistochemistry and FACS analysis, and we established FACS analysis of the endometrium NK cells in our own lab, and it's quite interesting data I did not bring today, but I hope to bring them next year. And I think this is a study Udo already showed us, the distribution of immune cells and macrophages, which differs depending also on the cycle. And this is also a study published from our group, from the Heidelberg data, and we saw higher peripheral NK cells in patients with primary recurrent miscarriage as compared to secondary. So patients with a live birth as compared to patients without a live birth. And you see this is true for the CD56 uterine NK cells as well as for the CD16 peripheral NK cells. And then we published a second study 2 years ago and included quite a large number of patients with recurrent miscarriages and used the WHO criteria. And you see nearly 400 patients with primary recurrent miscarriage as compared to nearly 200 with secondary, and also quite a high number, nearly 50%, which did not have an established risk factor in both groups. And there we could confirm our earlier data, and we could show that patients without a live birth in their history have quite higher CD16 positive PNK cells. And as CD16 is an activity marker, I think this is quite interesting. And there we are now having more detailed studies. And you might question what's about the subgroup of patients with idiopathic recurrent miscarriage, and there the significance is even higher, like we would expect. But what is the mechanism? Why do we think that we should have a look on the subgroups of patients with recurrent miscarriage? We think that there is something like a fetal microchimerism, which leads to a chronic stimulation of the maternal immune system, and that some patients with recurrent miscarriage, especially those with a live birth, have an altered adaptation, and this ends up in a miscarriage in the next pregnancy. But as we discussed before, we have low priority research funding and we have insufficient fundamental research. So what about the data if we want to focus on targeted therapy? So here we have an endometrial biopsy with a huge amount of uterine NK cells, and we look whether lipid infusions can be an option. And I think it's very interesting that David Clark, maybe some of you know him, he's a colleague which is focusing on reproductive immunology since, I think, 40 years, and he lives in Canada. And it was as early as in 1994 that he stated that it can be hypothesized from the human clinical trial data that intralipid, so lipid infusion, even in small dosages, could be an effective anti-abortion treatment in 1994. And why is this? Because we know from patients that if they are exposed to lipid infusion, we see alterations in the intra, but also in the extracellular signaling. And here you can see data of inhibitory effects when we give lipid infusions here with endothelial cells. So what do we expect from lipid infusions? We know that they're given routinely in patients during intensive care time, like a parental nutrition. They contain soybean oil, glycerine, and egg phospholipids. And we know so far that they lead to reduction of pro-inflammatory cytokines, TNF-alpha, interleukin 2, and NK cell suppression. Of course, when the patients come to us and has, for example, a flu or other kind of infection, we have to be careful, and we definitely in our clinic do not give lipid infusion, because then we might have an increased systemic immune response. So with those patients, please stop the lipid infusions. This is another study showing that the lipid infusions can be incorporated and definitely have an effect on endothelial cell integrity. And I think it's mainly the group of we have some interference with our slides, but I do not hope that you have it. So it's mainly the data from the group of Caroline Cullum, which showed that in patients with recurrent miscarriage, as well as patients with infertility, there is a positive effect on the live birth rate when they get lipid infusions. And that's also a study from the Cullum group, which showed equi-effectivity of lipid infusion as compared to IVIG in patients with recurrent miscarriage. And we all know that lipid infusions are not that costly than IVIG. And so this is also from the Cullum group, because they thought, how long can we have an effect of the lipid infusion? So how long is the duration? They had 50 patients with abnormal PNK activity, and nearly 80% normalized in their PNK activity within 1 week. And we see that in patients with quite high cytotoxic activity, the effect stayed for 9 weeks. And even in patients with low activity, the effect stayed for 8 weeks. That's why in our clinic, when we see that patients have high peripheral or uterine NK cells, we give the lipid infusion every 8 weeks until the patients are pregnant, and then continue with lipid infusions every 2 weeks until the 12th week of pregnancy. But there are some more data, so randomized controlled data about high peripheral NK cells in patients with recurrent miscarriage. It's a little bit like the Cullum study I showed you before. They also compared IVIG with lipid infusions, and although it was not significant, there was nearly the same live birth rate. And I think this also stresses that lipid infusions which are not expensive, have the same effect than IVIG. And this is a study by the Daki group. They mainly looked on the clinical pregnancy rate when they gave lipid infusions to patients with recurrent miscarriage and high PNK. And with the clinical pregnancy rate as main outcome, they did not see significant differences. But with the live birth rate, they had significant differences. So this is also a quite nice study. But I do not only want to talk about lipid infusions, and I also want to share some data about corticosteroids. And of course, the main studies or the first studies came from the group of Xiaoben Quanby. I know her because we were both in the sick of the ESHRE, and they gave 20 milligrams of corticosteroids in the luteal phase in patients with high uterine NK cells and saw a decline within the next cycle. And this study, or nearly the same study, was done of the Cooper group, and they had patients with unexplained recurrent miscarriage. You see more than 100 patients. They did a biopsy during the luteal phase, and I think they have a quite high number of patients with high uterine NK, you see here. And then they gave a lower dosage, so only 10 milligrams in 36 patients, and repeated the biopsy. And in half of the patients, the UNK cells dropped. And in nearly 10 patients, it dropped, but not to normal range. And at least in 6, there was no reduction. Here you can see the data. There are some more data from the Quanby group in patients with idiopathic recurrent miscarriage, low group, also high UNK percentages, and they did not show significant differences. As I mentioned before, they are giving quite high dosages. And that's all. We are still lacking more studies on corticosteroids in patients with recurrent miscarriage. To end up, I want to discuss with you another marker, so ACG, giving in patients with ART and recurrent miscarriages. And I'm sure you all know that there are some promising data about that. Why is ACG an interesting treatment? Because we know the local effects on the uterine vessels, on the endometrial cells, on the immune cells, and also on the ovaries. And Laurencio Gracianus, which is part of our SIG at the ESHRE at the moment, he did a very nice Cochrane review on the intrauterine administration of ACG in subfertile women undergoing ART. And at least they could include 16 studies. I think that's not that low. But there was, of course, a risk of bias because the patients did not only receive ACG. And here you can see the outcome with regard to miscarriage, and there was no clear favor of ACG treatment. But with regard to live birth, it was also no favor for ACG treatment. And if we have a look on the group, it's mainly patients not with a blastocyst transfer, but with a day 2 to 3 transfer, which might benefit from ACG administration. And I also think we are lacking more data. So to sum up, I think we have some open questions. With regard to the plasma cells, as Udo showed before, we have quite good evidence, but we have no placebo-controlled trials. With regard to the NK cells, we have the peripheral, we have the uterine, and I think you realized also when we showed the data for the corticosteroids, and we compared the Sheob and Cranby data to the other data, that there are so different kind of reference ranges. This is true for the peripheral as well as the uterine NK. So we definitely lack a standardization. And as I mentioned in the study from Daki, we have to look on the endpoint, because although the clinical pregnancy rate might be interesting, we are all going for a live birth rate, and we definitely lead placebo-controlled trials. About the ACG, I think this is a very promising marker, especially for us as a clinician. But we need to know when is the best time for ACG administration. It's immediately before the transfer or days before. And about the concentration, because it's all about the amount of fluid you're giving inside the uterine cavity. And I think we all agree about that. And my last two slides, I want to stress another topic we have to be aware of. When we deal with patients with recurrent miscarriage and we think about possible immunotherapy, we have to be aware that the perinatal outcome in a subsequent pregnancy of women with recurrent miscarriages might be altered. And I think this is a very nice study published 6 years ago, that we have to deal with patients which are higher, which do have a higher risk for preterm birth and very low preterm birth, as well as perinatal death. So thank you for your attention, and many greetings from me and the whole team from Innsbruck.
Bettina, thank you so much for your presentation and question, of course. Firstly, I will stress that I fully agree with you that the problem of meta-analysis in immunological treatment, that is not false conclusion to me, that is no effect but no target. I absolutely agree. As you shown is your slide, patients with primary and secondary recurrent miscarriage have a different type or different level of NK cells. So does it mean that they need absolutely different algorithms or treatment or diagnostic? Of course, after excluding all other reasons, chromosomal pathology, antiphospholipid syndrome, and so on.
Yeah, I really think that the mechanism we were hypothesizing, that there are a fetal microcharism, is something we have to keep more in mind. And as I mentioned before, I think the activity markers of the NK are quite promising, and because it's much more easy sometimes to do the peripheral NK cells, because then we can do FACS analysis and we can do a whole bunch of markers. And I think all of us have our difficulties in the interpretation of the studies we have so far, so the few studies. And also we have a little bit problems to use immunotherapies without clear data. And I think if we have a target, and if we focus like on NK cells and we really go in detail, then I would recommend to apply immunotherapy and then to make a check preconceptionally, so that we really see, is there an effect? Because if we believe that there is a target and that the NK cells are different, especially in patients with secondary recurrent miscarriage, we should be sure that we have the right treatment. Because in our clinic, we start with lipid infusion, of course, but if there's no reaction, we go to corticosteroids, or we have other options. And I think that's very important. And it's very difficult to convince the patient to wait for some more months. But I think it's necessary because so far, especially with regard to patients with secondary recurrent miscarriage, we have the IVIG data from Ole, and we all know it's not only about IVIG, but it's also low molecular weight heparin, which was given, progesterone, which was given, so that we cannot be sure that's the IVIG. And I think in whole Europe, IVIG is quite expensive and patients cannot afford that treatment.
Thank you. Could you please open your secret about lipid infusions? How do you use them? How often? Till which term of pregnancy?
Yeah, it depends a little bit. As I said before, due to the Hallam data, we wait for 7 or 8 weeks until we give the next intralipid or lipid infusion, and we give a low amount. So we gave like 8 milliliters in 200 milliliter saline. And we started before the pregnancy every 6 to 8 weeks. And when the patient is pregnant, we continue it in a 2-weekly manner. So every 2 weeks we give the infusion until the 12th week of pregnancy. But of course, it depends a little bit when the miscarriage took place.
Okay.
We can go a little bit longer with the lipid infusion.
Yeah. Thanks. It's clear. And do you control in some way effect of infusion? Measure NK cells, something else?
Yeah. If we have patients with high peripheral NK cells, then we have the possibility to control it.
Okay. Okay. It's okay. One more question. You've mentioned that majority of RPL patients have high level of NK cells, but sometimes we can find patients with low level. They need absolutely different strategy. Could you comment this statement?
Yeah. As Udo and I developed the endometrial biopsy together 9 years ago, we know that the percentage of women with low uterine NK cells is quite low. And it's difficult to state whether they might benefit from like GCSF intrauterine, which I prefer, or whether they benefit from GCSF, which is given subcutaneously. And we are lacking studies. That's the problem.
Okay. Thank you so much. It was really very impressive and very helpful for all of us. And I thank you so much for your participating, for your sharing of your knowledges. And I wish you nice day today, nice weekends, and I hope sometimes you will be able to visit Kyiv. It will be great.
Yes, thank you for the invitation. It was a pleasure.
Thank you. Bye.